Hi everyone, we're Christine, Ashlyn, Jury, Sojan, and Alan, members of group number 6, and this is our final group project for the Economic Evaluation of Pharmacy and Pharmacy Practice course. In this video, we'll analyze a pharmacoeconomic evaluation published in the Journal of Medical Economics titled Cost Effectiveness of Subdermal Implantable Buprenorphine versus Sublingual Buprenorphine to treat opioid use disorder. Before we jump into the analysis portion, this is an overview of the topics we'll be covering today. First, we'll provide an introduction to the opioid use disorders, what it is and why it's important. Next, we'll provide a brief summary of the article, including its aims, methods, results, and conclusions. Lastly, we'll analyze each of the elements listed on the slide for the article. As I'm sure you know, these are all the elements we read about in Chapter 3 of our course textbook, where we learn how to critique research articles and assess for bias. We'll start off with a brief introduction to the topic of the article, which is opioid use disorders, abbreviated OUD. Over 2.4 million people in the U.S. suffer from OUD, which is defined as the compulsive use of heroin or prescription pain medications despite adverse social, psychological, or physical consequences. OUD certainly is not a harmless disorder, as patients who suffer from OUD have an increased risk of HIV, hepatitis, skin and blood infections, overdose, and opioid-related deaths. The number of opioid-related deaths has increased 400% since the year 2000 and now account for 91 deaths every day in the U.S. The terms opioid epidemic and opioid crisis have been used to describe the magnitude of this impact on human life and society overall. In addition to the costs in human life and productivity, there's a large economic impact of OUD as well. Individuals who suffer from OUD have direct medical costs nearly 9 times those of who do not have OUD, and the total estimated annual medical and societal costs add up to $62 billion. Evidently, OUD has a huge health and economic impact and is an important issue that needs to be researched and addressed. So now that we have a better idea of what opioid use disorder is and its impact on health and the economy, we can start critiquing our article. Essentially, our article assessed the cost effectiveness of subdermal implantable buprenorphine against sublingual buprenorphine. The author stated that subdermal implantable buprenorphine was recently approved to treat opioid use disorders in clinically stable adults. And in a pivotal clinical trial, subdermal implantable buprenorphine was associated with a higher proportion of completely abstinent patients. In other studies, relapse to opioid use is associated with poor outcomes and increased costs. This study aims to synthesize the clinical outcomes aspect as well as the cost aspect as a pharmacoeconomic evaluation. The authors used a Markov model, which is a specific type of model in probability theory, to simulate 4 different patient cohorts going through 4 different health states, namely on treatment and not relapsed, on treatment and relapsed, off treatment and relapsed, and patients who passed away. The probability of transitioning to a relapsed state were derived from a previous trial. Each of the cohorts accumulated direct medical costs from drug acquisition/administration, treatment diversion or abuse, newly acquired hepatitis C, emergency room, hospital, and rehabilitation services, and pediatric poisoning. They also accumulated non-medical costs from criminality, lost wages and work productivity, and out-of-pocket expenses. The outcomes that were assessed in this article include incremental cost per quality gains and incremental net monetary benefit.
Now let's look at the specific part of each article. The first is title. The title of the study is Cost Effectiveness of Subdermal Implantable Buprenorphine versus Sublingual Buprenorphine to Treat Opioid Use Disorder. There are a few components of the title to note to assess the completeness of the title. First component is whether the title states the type of study conducted. The title says that this study is cost effectiveness analysis, but since the outcomes were reported in QALYs, the study is technically a cost utility analysis. However, taking into account the cost utility can be considered as a subtype of a cost effectiveness analysis, the completeness of the title in regards to mentioning study type can be argued. The second component is whether the title states the comparator used in the study. And yes, this is mentioned. The title contains both subdermal implantable buprenorphine and sublingual buprenorphine. The third component is whether the title sounds biased. And since no conclusion can be drawn from the title alone, the title is not biased. The next is objective. The objective of the study is to evaluate the cost-effectiveness of subdermal implantable buprenorphine versus the sublingual buprenorphine from a U.S. societal perspective. This is an incomplete objective since it fails to state the type of study and is conducted and the target population of the study. Moreover, it should be noted that the objective is only specifically mentioned in the abstract. The next is alternative. The alternative used in the study is sublingual buprenorphine. To assess the appropriateness of the alternative, we looked at the national practice guideline from the American Society of Addiction Medicine. The guideline states that sublingual buprenorphine is approved and recommended agent for opioid use disorder and withdrawal. Thus, it is an appropriate alternative to be used. To further assess if the alternative is appropriate, we looked at if the alternative is described in the study. The study does include the description of the alternative. It is stated the modeled sublingual buprenorphine cohort received 8 mg per patient per day. The duration of the therapy is 12 months, and the details of the service provided is not stated as the study compared to pharmaceutical products. However, it should be mentioned that the study only states the description of the alternative in the discussion section of the paper and not earlier on, such as method sections.
We will now look at whether or not the perspective was stated. In order for the readers to know whose costs were measured, the study addressed that it was from a societal perspective. The article states that a Markov model was conducted from a U.S. societal perspective and also states that costs associated with clinical and societal penalties of relapses and illicit opioid use were drawn. Now we will look at whether or not the type of study was stated. The type of study was not stated because the article does not mention that the study is a cost-utility analysis. The type of study is also not mentioned in the title. Although the title does contain the words cost-effectiveness, it does not explicitly say cost-utility. It can be argued that cost-utility analyses are a subset of cost-effectiveness analyses, but the outcomes were reported in the quality-adjusted life years, and the study is more accurately a cost-utility analysis. We will now look at appropriateness of the cost measured. The appropriate costs were not measured based on the type of cost assessed because only direct medical costs and non-medical costs were included. However, indirect and intangible costs should also be measured because this analysis is a societal perspective. Secondly, it is uncertain whether or not costs were collected for an appropriate time period. Even though the authors did mention that all costs were adjusted to 2016 USD, the time frame of these costs was not specified. The study also did not justify why indirect and intangible costs were not included in this analysis. Additionally, costs were drawn from observational studies and administrative claim analyses of the economic burden of opioid use disorders, and there were no protocol-driven costs mentioned in the analysis. Now we will look at whether or not the measured outcomes were clearly stated. The authors of this study explicitly stated that the primary outcomes were the incremental cost-effectiveness ratio for subdermal implantable buprenorphine, cost per quality adjusted life year gained, and the incremental net monetary benefit of subdermal implantable buprenorphine compared to sublingual buprenorphine. However, these outcomes are not clinical outcomes that would be important to clinicians because clinicians tend to be more focused upon specific impacts rather than cost. When clinicians decide to use a specific formulation of drug over another, they consider factors such as convenience, efficacy, and safety. They would then consider insurance coverage of the medications as well, since most patients cannot afford expensive therapy. These outcomes were measured for an appropriate time period. Clinical evidence that compared the two interventions had a follow-up of 6 months. By using the Markov model, the data was extrapolated to 12 months. Guidelines from the National Institute on Drug Abuse recommend patients to be on opioid use disorder substitution therapy for at least 12 months. So we can say that these outcomes were measured for an appropriate time period.
The next section talks about adjustment and discounting. We first looked into if the study data was collected for more than a year. The data was not collected for 1 year. As a matter of fact, it was collected for 6 months and was extrapolated to 12 months. The second component asked if adjustments or discounts were conducted, and the answer to this is yes. Costs associated with relapse and illicit opioid use were obtained from observational studies, which were identified through a targeted review of the peer-reviewed literature and administrative claims. The article also explicitly stated that all costs were adjusted to 2016 US dollars. Next, we'll be assessing if the article has reasonable assumptions. The first component is if the assumptions are stated explicitly. Assumptions in this article were not all explicitly stated. Some explicitly stated assumptions were that they based the dosing of the model sublingual buprenorphine cohort of 8 milligrams per patient per day from a pivotal clinical trial. The article also explicitly mentioned that the population was assumed to be clinically stable. Some assumptions that were not explicitly mentioned was in regards to the cost of a BSI implantation and explantation. The authors had to estimate the cost as reimbursement codes for the procedures were not available for BSI yet. Another assumption was made by the authors were the willingness to pay cost per quality, as the article overall does not state how they set this cost. Second component is if the assumptions are reasonable. Most assumptions were based off of outcomes from a pivotal phase 3 clinical trial. However, these assumptions were unreliable and unreasonable as the trial itself had different interventions and duration of treatment as well as outcome measures. We also looked into the sensitivity analysis of the article. The first component assessed if the sensitivity analyses were conducted for important estimates or assumptions. In these, sensitivity analyses was performed to assess the impact of a Markov model and how well it simulates reality. The authors used two different methods to assess the impact. We also looked if the results were robust to sensitivity analyses. The results were not robust to sensitivity analyses as there were conflicting results. If the overall results, such as whether the same intervention is cost-effective or not compared to the alternative, changed with the sensitivity analysis, then the results are not robust. With the INMB, it changed from positive to negative, whereas the PSA revealed that the median net monetary benefit of BSI was significantly higher. These conflicting results in the end show the decreased confidence in study results. This is a scatter plot of the PSA cost per quality outcomes of 1,000 iterations. Quadrant 4 is dominant as it shows more qualities with better outcomes but less costly, whereas Quadrant 1 was more costly and more effective, but we are not sure how much it's worth, which is where the incremental net benefit comes in.
The authors acknowledged the limitations of their study. Since implantable subdermal buprenorphine, or BSI, was only recently approved in the U.S., there is limited real-world data of BSI use. As a result, the authors used a Markov model to simulate cohort outcomes to determine the cost-effectiveness of BSI versus sublingual buprenorphine. Since their economic model is not a perfect representation of the real world, they modeled their data after real-world analyses with study populations similar to theirs. The authors did not over-exaggerate their conclusions. Their conclusion was limited to the same population that their economic model was based off of, which were opioid-dependent, clinically stable adults. The authors also chose an appropriate alternative, which was sublingual buprenorphine. This is currently one of the first-line therapies for opioid use disorder. As previously stated, they also compared their model data with real-world data to make sure that they made reasonable estimates in order to calculate cost effectiveness. For example, the sublingual buprenorphine cohort had a total direct medical cost of $22,031, which fell within the range across 5 administrative claim analyses. They also admitted that their estimate fell on the lower end of the range because commercial claim analyses tend to report higher observed costs than modeled ones and include unstabilized patients along with stabilized patients. So any discrepancies between modeled data and real-world data were explained by the authors and a rationale was provided. The study also does not mention any extrapolation of the population, so it mentions that the patient population was assumed to only include clinically stabilized adults. So overall, the article had some strengths and some weaknesses. The weaknesses were the article did not explicitly state that the authors conducted a cost-utility analysis. The objective, specifically the method of analysis and study population, was not clearly stated in the beginning of the article. Indirect and intangible costs were also not included. Some of the assumptions were arbitrary. The authors neither stated how they obtained a willingness to pay value of $50,000 as the cost-effectiveness threshold, nor rationale for it when calculating ICER and INMB. And since the univariate sensitivity analysis resulted in a negative INB and positive INB when changing differences in relapse probability between treatments, the economic model used may not be robust enough. In conclusion, this is not a perfect article. And these are the references that we used. And that concludes our final project for the economic evaluation course. Thanks for listening.